Lamont, thank you very much. Senator Byrd, do you want to introduce your other guest?
Thank you, Mr. Chairman. I'd like to introduce to my colleagues Dr. David, is it Hogberg? Good. Who's the Healthcare Policy Analyst at the National Center for Public Policy Research here in Washington, D.C. Dr. Hogberg, thank you for joining us today. I look forward to your testimony and thoughts as we examine the lessons learned from other abroad countries in order to strengthen our own healthcare system here at home. The mic is yours.
Chairman Sanders, Ranking Member Burr, members of the committee, thank you for this opportunity to testify before you. My name is David Hogberg, and I am a healthcare policy analyst for the National Center for Public Policy Research. I think the most important lesson we can learn from other nations is that we should avoid putting more and more of our healthcare system under the control of politicians. Most politicians want to get reelected, and that fact will have a substantial impact on healthcare policy. Groups that have political clout that can influence a politician's reelection chances are more likely to get good treatment under government-run healthcare systems. Groups that lack such clout are more likely to be neglected by politicians and receive inferior care. People who are very ill usually lack such political clout. First, the very sick are relatively few in number, which means they amount to a very limited number of voters, too limited to have much impact on elections. Second, they are too sick to engage in the type of political activities such as organizing, protesting, and so forth that can bring about change in healthcare policy. Ultimately, under a government system, those with the most medical need are those most likely to have difficulty getting the care they need. Both Denmark and France provide good examples of this. The healthcare system in Denmark could be best described as single-payer, with the government financing over 85% of healthcare expenditures. Healthcare in Denmark is largely free at the point of consumption. This has consequences for how healthcare resources are allocated. If patients pay nothing at the point of consumption, then patients will overuse healthcare, putting strain on government budgets. Healthcare must be rationed in another manner. And like most systems that are single-payer, Denmark rations by using wait times for treatment of serious conditions. For example, Danes must wait a median of 48 days to get a herniated disc repaired, 57 days for a knee replacement, and 81 days for cataracts treatment. Under the national standard for cancer treatment in Denmark, a patient should not wait more than 28 days between the time he sees a physician for diagnosis to the time of treatment. However, a 2010 study found that less than half of Danish patients diagnosed with head or neck cancer were treated within that national standard. This can have serious consequences for patients. A meta-analysis found that for every month treatment is delayed for head or neck cancer, the probability that the cancer will recur increases by about 3.7%. Now, looking to the French system, the healthcare system in France is financed heavily through the government, yet also has an extensive market of private insurance that covers co-payments and services the government does not cover. When a patient visits a physician in France, he must pay the cost directly. He is then reimbursed by the government and the private insurer. The patient must cover any cost that is not reimbursed. The method of payment and the extensive system of private finance is what allows France to avoid using wait times to ration care. However, the healthcare portion of France's budget has been running a deficit since 1988. As a result, the healthcare system in France has used other methods to ration care. One rationing method is limiting investment in new medical technology. Among industrialized nations, France has one of the lowest number of CAT scanners, PET scanners, and MRI machines per million population. Rationing pharmaceuticals is another method. In brief, the French government often refuses to pay for drugs that are incremental improvements over existing drugs. Such rationing has consequences. According to one study, only about 1/4 to 1/3 of Alzheimer's patients in France are receiving state-of-the-art medication. Rationing technology and medication, or using waiting times, falls hardest on people with serious illnesses. Yet these methods persist because they are politically tolerable. In general, they do not cause trouble for politicians, since the people affected seldom are a significant political force. In summary, I think the chief benefit of an examination of other nations' healthcare systems is to discover what policies we should avoid. That said, it would be far more productive if we instead studied other markets rather than other nations. That would include other markets for insurance, such as life, homeowners, and auto insurance, and other markets for other vital products, such as food and clothing. There you will find markets in which government tax policy hasn't distorted the purchase of goods, where tax policy and regulation have not resulted in a three-tiered system of insurance, and where consumers are not prohibited from buying goods and services out of state. As a result, these markets reduce the cost of goods and services while also improving quality. It is in these markets that we should look for guidance in reforming the U.S. healthcare system. Thank you very much.